Assalamu alaikum wa rahmatullah. I'm Dr. Wael Hussein, and I have the privilege to be part of this series prepared by SAMA, the Sudanese American Medical Association, about nephrology practice in low-resource areas like in Sudan. Today we're going to talk about acute kidney injury, a condition that if you recognize it early and treat it, it can make a difference between life and death, and it can prevent people from progressing to dialysis. Today we're going to talk about when to suspect it, because you need to suspect it so that you can look for it, and how to look for it, how to diagnose it, how to manage it, and how to manage the complications associated with it. So let's start with the definition. There is a formal definition and there is a practical way of thinking about it. The bottom line is that acute kidney injury means an acute or rapid deterioration in kidney function. A rapid decline in kidney function is reflected by a rapid rise in the serum creatinine. The formal definition by KDIGO involves a timeline. It involves specific numbers in the serum creatinine or a deterioration in the urine output. The problem in practice is that time is of the essence, and you do not want to wait until you meet the formal definition, but you need to act on what you have. You can have a single creatinine, and you need to make decisions about whether this is acute or chronic and what you're going to do about it. And you might observe the urine for a very limited amount of time, and you need to make decisions based on that as well. Why should we care about acute kidney injury? It's because, one, it's very common among patients who are in the emergency room. It's very common among hospitalized patients. It is associated with a high mortality and morbidity, and it is a preventable condition. This is an important slide in the presentation. It's basically the framework for how you should think about acute kidney injury. The way you think about it, it follows the flow of the fluid from the circulation into the kidney and then out of the kidney. Before the kidney, we group these causes as pre-renal, and then you have within the kidney, we call these intrinsic renal or intra-renal, and then you have the post-renal in the ureter, the bladder, and into outside the body. An important point that I keep highlighting in this talk is that hypoperfusion is the most common and one of the most important causes of AKI. And you see that word highlighted in pre-renal and in the intra-renal categories. The reason being, initially, if you don't have enough blood supply to the kidney, or the circulation is compromised to the kidneys, you get AKI. But if that insult is prolonged or severe, you get ATN, acute tubular necrosis, and that's intrinsic kidney disease. The first one, the pre-renal, if you correct it, you expect a rapid improvement in the kidney function. But if ATN was to develop, you would expect that the recovery will take longer. Now, going back to the pre-renal causes, just focus on the fact that we called that group as hypoperfusion, and we didn't just say hypotension, dehydration. Don't forget that hypervolemia can cause hypoperfusion, and this is in the setting, for example, of heart failure or liver failure, hepatorenal or cardiorenal syndromes. So that's pre-renal. When you start thinking about the intrinsic renal or the intra-renal, you need to think about the components of the kidney. You have the blood vessels, so renovascular disease, and there are the vasculitides that affect the kidneys. Then you have the glomeruli, so you have different types of glomerular disease. If they're associated with AKI and rapidly rising creatinine, this group is called the rapidly progressive glomerulonephritis. Then you have the tubular interstitial disease, including ATN that we talked about. It can happen in the setting of hypoperfusion, but it can also happen in the setting of toxins directly affecting the kidneys. You can have acute interstitial nephritis as a reaction to certain pathogens or certain drugs. Then you have the post-renal, where you have blockage to the flow of the kidney. Just remember that if only one kidney is affected, you might actually have a lot of damage before you see a rise in the creatinine, because the other kidney is compensating for the kidney function. Common causes are obstruction at the level of the prostate in males. You can have cervical cancer in females, or you can have renal stones. Your management of acute kidney injury actually starts by suspecting it. It needs to pop up in your mind if you're seeing a sick patient, if you're seeing somebody who has dehydration, shock, or sepsis, if they're exposed to toxins like nonsteroidal anti-inflammatory drugs, if you have a patient who is presenting with obstructive symptoms, and if you have systemic signs or symptoms, for example, in a patient with rash and joint pains, if you're suspecting some sort of an autoimmune disease. So always keep it in mind if you see anything that is known to be associated with acute kidney injury, because then you will be able to look for it and will be able to manage it. How would you recognize that there is AKI? The first thing is that you have to look at the serum creatinine. And you will see a high serum creatinine. Then there are things that you have to do, or questions that you have to ask yourself. The first question is, what is the baseline? Because you might have somebody with a high serum creatinine, but it's a chronically elevated serum creatinine. And the way to figure that out would be to look at the bigger picture. If, for example, if you're seeing a patient in the clinic, in the outpatient department, who is completely asymptomatic, or even if you're seeing them in the ED because they came in and had an injury in their foot, for example, this might not be acute kidney injury given the bigger picture. And it's more likely to be chronic kidney disease in a patient with, for example, diabetes or hypertension. And you need to treat that differently. However, if you have a patient who is sick, coming in with dehydration from vomiting and diarrhea, that's a completely different way of thinking about it. You have a high serum creatinine, you have to consider that as acute kidney injury until proven otherwise. Then the next thing you do is you're going to follow that up. You're not going to rely on just one serum creatinine, not only because you want to prove that this is AKI or not AKI, but because you'd like to see the effect of your management. So you might need to repeat the creatinine, and how frequently you repeat it will really depend on the clinical scenario. Then if you have a patient with low urine output, this commonly happens in patients who are post-surgical, or somebody who's in the ICU you're following the urine output on hourly basis. Then you will be able to spot low urine output, and you'd like to respond to that by checking the creatinine and checking that whether they have AKI or not, and then managing it as well. As you're doing your overall management, always just keep it in mind. As you're doing your history, you're looking for features of volume overload or dehydration and hypovolemia. You're looking for features of systemic disease with skin rash and joint pain. You're looking for medications that can affect the kidneys. And then on your exam, again, you're examining for the volume status of the patient, and you're looking for features of heart failure or infections or a systemic disease as well. And then you're sending your laboratory tests. We're going to talk about that in a separate slide. And eventually you do your imaging. Usually if it's just for acute kidney injury, you would want a renal ultrasound. And if the cause is obviously related to sepsis or dehydration, you probably are not in a rush to get the renal imaging. However, if you still don't know what's going on and obstructive features are if you have high suspicion for obstruction, you might need to rush the imaging. The other reason you would like to know the imaging is if you're considering a kidney biopsy and you'd like to know what's going on with the kidneys. Now, if you do remember, in an earlier slide, we said that hypoperfusion is the most common cause of AKI. And following from there, volume assessment of the volume status is an important element in your evaluation of the patient with AKI. Not only because it will help you understand why the patient is in AKI, but also remember that if the patient has advanced AKI from hypoperfusion and has developed ATN, that while you're resuscitating them, you're not expecting an improvement in the urine output immediately. It will take longer if they developed ATN. So how do we do the volume assessment? Now, this is easy if the patient is at the extremes of hypervolemia or hypovolemia. If the patient is significantly hypervolemic, it's obvious. They have a raised JVP, they're edematous, there's bisal crepitations when you examine their lungs. It's a very obvious assessment to make. At the other extreme, if the patient came in with diarrhea and vomiting or had significant bleeding, and then you're looking at the neck veins and they're collapsed and they look dry and their blood pressure is low, that's the other extreme where you know that the patient is hypovolemic and you need to volume resuscitate quickly. There is a group of patients who lie in between, and it's very difficult to make a call about whether they're hypervolemic or hypovolemic. And if you're in that spectrum, what you need to do is a fluid challenge. So how do you do that? You give a bolus of fluid and you follow up. The key thing here is the follow-up. After you give the bolus of fluid, you observe the change in the blood pressure, in their respiratory function, and in the urine output. And then you make a decision about whether you seem to be going in the right direction. If the patient starts to perk up, the blood pressure improves, there probably is improved urine output, you're probably going in the right direction. Versus if the patient starts to have respiratory compromise and there is no real response, blood pressure improves a little, but then started to deteriorate, and your examination is now showing features of pulmonary edema, for example, you know you're going in the wrong direction and you need to stop. So it's a precarious position to be in. The key thing to remember again is after you give the fluid bolus, you really need to follow. You might need to give another fluid bolus or continue the IV fluids, but you observe carefully because you might be going in the wrong direction and need to catch yourself early rather than late in the way that you're giving the fluids. The next question is, what investigations do we need to send for a request? The obvious one is the creatinine and the full renal function, meaning checking the urea, checking the electrolytes, mainly the sodium and potassium, and if you can, get the bicarbonate as well, because you need to know about the acid-base balance of the patient. Other blood tests that can be helpful include the CBC. You're looking for features of sepsis. You're looking for, if you have, for example, a low hemoglobin and a low platelet, you might be starting to think about hemolysis. You might be starting to think about TTP and the likes. You need to check the calcium, the albumin, the phosphorus. They can have associations with, for example, multiple myeloma, the liver panel in HUS, or in hepatitis diseases, hepatitis B or C, which are associated with kidney damage. Other tests are going to be determined by what the patient condition is. Always, 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 please, please, please do a urine dipstick or urinalysis. What you're looking for mainly is whether there is blood and protein in the urine. And a more sophisticated test is the urine protein to creatinine ratio to understand how, or to figure out how much protein is there in the urine. Probably not as important in the setting of acute kidney injury. But if you have somebody with sort of rising creatinine, but not very acutely, and particularly if you're suspecting things like nephrotic syndrome, you would like to get the urine protein to creatinine ratio. Microscopy is important because you're looking for red cell casts or dysmorphic red cells, which will indicate that the blood cells are coming from the glomeruli and indicate that there is a glomerular disease. And in the setting of acute kidney injury, this might be rapidly progressive glomerulonephritis, which requires immediate attention. It requires send out of certain serologies and plus or minus a kidney biopsy and immediate response to save the patient from getting into end-stage kidney disease or even the patient's death. However, further discussion about this will come in a different lecture. The renal ultrasound is not crucial if the picture is obvious that the patient has hypoperfusion, but once the patient is stable, you would like to get a renal ultrasound for several considerations. Definitely, if you are suspecting obstruction, you need to get that early on. Well, even if not, if you're considering a kidney biopsy, you would like to get a renal ultrasound as well. If you're suspecting a chronic element, or if you don't know what's happening as well, renal imaging might actually elucidate the cause of kidney damage. The management, unfortunately, we do not have a drug that we give for acute kidney injury. So the management is remove the cause and prevent other causes of kidney injury, and then wait. Look for complications. If they're there, you need to treat the complications. And if you cannot if you cannot control the complications with medical management, you might have to do dialysis. That's the essence of the treatment. And the thing that I want you to always remember, treat the patient, not the creatinine. The reason is the creatinine might lag behind the insult and it lags behind the treatment as well. So always look at the patient. If the patient is starting to improve, the patient was hypotensive, now the patient blood pressure is better. Or the patient had problems with breathing, now the patient can breathe comfortably. These are more important than just following the serum creatinine or following the urine output. Even the urine output, if you have ATN, the urine output might lag behind the improvement in the clinical condition. So fix the underlying cause, fluid if the patient is hypovolemic, if the patient is overloaded, it's diuretics. And then this brings to mind an important misconception that people have. You would hear people saying, the patient is in renal failure, we have to give him fluid. Or the patient has low urine output, we have to give diuretics. No to the first statement, no to the second statement. Think about what is it that you're treating. If the patient is hypovolemic, give fluids. If the patient is fluid overloaded, you give diuretics. Because if we go back to the statements, the first statement, the patient is in renal failure, let's give him fluids. But he might be in renal failure because of volume overload in cardiorenal or hepatorenal syndromes, for example. Although in hepatorenal, you might be giving albumin. That's a different discussion. Now, you might have a patient who, the other statement was about the urine output. The urine output is low, and you'd like to give diuretics, but what if the cause of the low urine output is hypovolemia and hypotension? You do not give diuretics for that. You need to give fluids. So always think about the patient, not about the items, not about the symptoms, not about the markers that you're following. The serum creatinine and the urine output are markers. Always think about about the patient and what's happening with the patient. Next, you look out for the complications. If there is fluid overload, of course, you give diuretics. If there is hyperkalemia, you give the potassium binders. You would like to treat medically as well. If there is acidosis, you can treat that medically. And in all of these, the next question becomes, when do you have to do dialysis? And the time that you have to do dialysis is that if you have any of these complications that you cannot manage or you cannot control medically. So if you have volume overload and the patient is not responding to diuretics, you need to do dialysis to take off fluids. If the potassium is high, you treat it medically, it's persistent, you see that the patient is still not making urine, you're not going to be able to treat that patient without dialysis. If the patient has severe acidosis that is not responding to your initial treatment, for example, fluid resuscitation and antibiotics in a septic patient, and or the patient is ventilated and severe acidosis, not making urine. In certain intoxications, you need to do dialysis to remove the toxins, or if the patient becomes uremic, it's affecting their mental status. And what I want to highlight here is that you need to be proactive. You do not need to reach a stage where everything is out of control before you interfere, because you need to put in a line for dialysis, and then you need to put the patient on dialysis. If the trajectory of the creatinine is going up very rapidly and there is no response, the injury was severe enough based on the clinical presentation, you probably, before you get to that level where everything is messed up, you probably need to proactively intervene, put in a dialysis catheter, and dialyze the patient. You're saving lives. So very briefly and very quickly, just a few cases. Rapid fires, let's say. Elderly man with diarrhea and hypotension. What's the likely cause? I think at this stage, everybody knows this is hypotension, hypovolemia, hypoperfusion. How would you manage this? You give fluid resuscitation, you observe, and you follow up the patient, and hopefully they will improve with volume resuscitation. If they have an underlying infection, you treat that. Now, before I move to the next case, when you see diarrhea, always also think about diarrhea-associated HUS. There are certain things that when they come, you have to think about the associations and consider them as probable causes. However, that last thing that I said is very rare. The most common thing that you would see is hypoperfusion and hypotension. Young man with muscle pain. Muscle pain from trauma, from drugs. If you have muscle pain, you need to think about rhabdomyolysis. If the CK is high, the treatment is fluids. You'd like to flush the CK out of the body so that it doesn't clog the flow of fluid inside the glomerulus. Urinary flow, and you give a lot of fluids and you aim for a lot of urine output. You have to be careful that if the patient goes into ATN and severe renal failure, that fluid that you give, that excess fluid that you're giving, is going nowhere. You don't want to flood them and then have to do dialysis to remove the fluid. So if they're not really responding to your aggressive resuscitation, you need to be careful and watchful as well. And there is a role, of course, in rhabdomyolysis to alkalinization of the urine, and that's a different condition that merits a different discussion. This third case is a postpartum woman with sepsis and oliguria. When you see sepsis, you think about hypovolemia and hypotension. There is extravasation of fluid outside the blood vessels. So that can contribute to acute kidney injury. However, sepsis itself, without hypotension, without hypovolemia, can be associated with AKI. So be watchful. If you have a septic patient, please check their creatinine, check their urine, and be aware that they can develop acute kidney injury. The treatment is the treatment of the underlying cause, antibiotics for the infection. Of course, you're going to do your blood cultures first, or your septic screen first, and then don't forget judicious fluids to restore the circulation. So here you have it. That's a very brief overview of AKI, what causes it, and how you should approach the patient. Remember, AKI is common, it's dangerous, it's associated with high mortality and prolonged hospitalizations. Patients may need dialysis, and if you don't treat it well, patients die. Patients may need chronic dialysis. It's associated with high cost, not only to the patient and the family, but to the whole community. Suspect it early, because that's the only way you're going to be able to catch it, and then you will be able to manage it. And the diagnosis relies on the clinical sense, then your serum creatinine and relevant labs, imaging, and don't forget the urine dipstick and urinalysis. Look at the urine under the microscope if you can. But don't forget the urine dipstick. That's a simple and easy one to do. Manage the volume carefully. Don't treat the creatinine. Don't treat the urine output. Treat the status of the patient. If the patient needs fluids, or if the patient needs diuretics, or if the patient needs inotropic support in the ICU. Identify the cause and treat the cause. Prevent further injury if you can. So I don't forget, I should have said that earlier. In terms of injury, for example, with certain antibiotics or contrast agents for imaging, you do not stop these if they they make a difference in the patient's management, and they make a difference that is life and death for the patient's management. You'd like to avoid them if they are unnecessary. Watch for complications, treat them medically. Failure of medical management means that you will have to do dialysis. Thank you very much.